Please pick an answer. All right. Common mistake here, right? People confusing cyproheptadine and bromocriptine. For which condition do I use bromocriptine? Anyone?
NMS.
NMS.
Okay. What's the other medication for NMS that we can use?
Dantrolene.
That's it. Guys, don't confuse this. This is very, very critical, and I promise you, it's likely to be on your board, or either NMS or serotonin syndrome and those drugs. So if you are confusing this, stop, look at the PDF. We cannot afford, because we are a team, we cannot afford to miss easy points. That's all about memorization, okay? So we have to get on it. Sorry.
That's the
Okay.
pin, please.
Oh, I don't have it in. Oh, yes, I do. 71
71
46
6
22
22
6.
6. Thank you.
Absolutely. So, guys, some of the boards will be wishy-washy, middle of the road, kind of like difficult to figure out what's the answer. But as far as medications and some of the stuff, there are raw memorization. All we have to do is our job, right? Some stuff it's like this we cannot afford. So, hopefully you guys getting the message that the message here is really work hard and let's get this done. All right, next question. All right, TM took the lead. She was fast. Or he.
I don't see the question on the board.
Okay, what's the treatment for NMS? Are you the only one that don't see the screen?
Yes, Dr.
Yeah,
Lopez.
I'm not seeing the question. Yeah, because there's 2 treatments for NMS, but I'm not seeing whether it's like muscle rigidity or.
See it. It's way up at the top. Short question.
No, like it literally doesn't show the question at all.
It's a short question. The screen looks blank when you first look at it. It's at the top.
Yeah. Great, guys. I don't know. So, sorry, this one should have been a 2 answer, right? So it's bromocriptine and dantrolene. So I'm not sure what you guys seeing there. I see the question and the answer from my side.
We see it too, Dr. Lopez.
Okay, all right. So it's just a short. Yeah, it's just a short, very little to the point facts. Question, right? So bromocriptine or dantrolene.
Dr. Lopez,
Now-
did you write down the code? I'm a little late. Did you write the code down to this?
Yes, 71 46 22 6.
Thank you.
Absolutely. So I want to warn you guys, for this question here, because it's likely, very likely, that the 2 answers will be in the question. So what am I talking about? Well, the question is likely to ask about NMS and give you a scenario in which they'll give you some symptoms. And then they ask you, which of the following medications belong to a category? So bromocriptine belongs to what category?
Is a dopamine.
D2 antagonist or something? D2, I forgot, but D2 I remember.
D2, yeah. Dopamine
D2 what?
antagonist.
Antagonist?
Anybody disagree or agree with that? You got to take a position whether you agree or disagree. There's only two possible ways, right?
It's
Come
an
on, guys.
agonist because
This is-
causing NMS meant you block D2 too much.
Okay. So is it agonist or antagonist?
Antagonist.
Antagonist.
Agonist.
It's agonist.
Agon.
Mhm.
All right. So let's take this. Let's bring this. Let's kind of think about this together. What causes NMS?
Antipsychotics.
Okay. Antipsychotics is D2 agonist or antagonist?
Antagonist blocks D2.
Okay. All right. So we've got to be NMS has to start with taking antipsychotics. And we know that antipsychotics are D2 antagonistic. Would you give a medication to fix a D2 antagonistic that is also a D2 antagonistic?
No.
No.
No. So therefore, you created the problem, quote unquote, by giving a D2 antagonist. Now what you need to do is to reverse that. And therefore, you give a D2 agonist.
I have a
Following?
quick question, Dr.
Yeah.
Lopez. That's why I kind of was asking about the question, because I said it's not showing me whether we're talking about muscle rigidity or if we're talking about like dopamine antagonism symptoms. That's why I was kind of confused. And then I saw what is the treatment for NMS. I know that you could do either or, but it's just they differentiate for two different reasons. So if it's asking me on the test, I'm gonna know for sure. But it's just because they didn't have it on here, I was kind of confused.
Yeah. No, it could be either one, right? Actually, that question I keyed in incorrectly because it should have been, I never do that, but that one should have been a two possible answers. Like you could click two. In a test, you won't have that. In a test, will say, they may not ever say this is a NMS. They'll give you the symptoms that are very clear that's NMS and ask you what medication would you suggest. And in that case, it will say pipe lead rigidity. And then in that case, you want to go for what medication? If it says pipe lead rigidity, which medications would you?
Dantrolene.
Dantrolene, right? So to relax. So muscle relaxes, dantrolene. If it asks for D2 agonistic, remember who created the problem? It's it's our problem because we gave the medication. So we have to own it. Now what we have to do is reverse it with D2 agonistic. Okay? So I trust that the person that you don't have to say your name, that pick cryptoheptadine, or either you just arrived or you click by mistake. But if you still have issues understanding the difference between cyproheptadine, bromocriptine, and dantrolene, please stay with me at the end of this, and then we'll kind of just talk a little bit offline. I just want to make sure that you guys are getting it, okay? No issues. All right, next question, please. All right, it might be a short answer, so the question might be on top, okay? Which OTC supplements can help with memory? Hard. Thanks to the premium. I think dimension. There's a type of dimension that is reversing. Only one, right? I know this is an odd question there. Probably didn't cover this in a test, so not as much at least.
Larry.
Okay, so remember that there is only one type of dimension that's oh, sorry guys. Talk about this in a second. How does this drug affect the use of enzymes? So if chamomile is a CYP3A4 inhibitor, what does it do? If you have any inhibitor, what do they do to the other drug? Right. So first, I want to before we'll go back here. So I want to talk about um the previous questions, right? There is one type of dimension that's reversible, at least one. All the others are irreversible, right? So when you get an older patient and they have the signs and symptoms of memory deficit, right? Make sure that you're checking your vitamin B12, right? Because it helps. Vitamin B12, it plays a critical role when you think of maintaining health nerves and cell production too, and producing what's it called, myelin, right? That protects the sheath around the nerve fiber. So if you think of it, it's also kind of like helps with the creation of helps with the creation of neurotransmitters and blood cell formation. So the point here is that only dimension that is reversible is vitamin B12 or by lack of it. So if there is a lack of it, the symptoms can look like dimension. So in the future, not only for the test, if you see someone that didn't have a dimension and they kind of start presenting like, make sure you get your vitamin B12 because it could be an easy fix. Okay. So now back to this question. Easy concept. If it inhibits, it prohibits the other drug from leaving the body. If the other drug cannot leave the body, what you will have an increase of the other drug. So if a drug is an inhibitor, it inhibits the other drug from leaving the body. Therefore, you have the increase of drug X. Can anyone, does anyone have a mnemonic or a better way of explaining this concept or a different way?
I think so. I gave the wrong answer, but I know what is the inhibitor and what is the inhibitor. It comes with the I, so I always remember it increase, and inducer comes with the D, so it decrease. But I gave the wrong
Perfect.
answer.
How come? What happened?
I was like, try to click that and
Okay, it happens. It happens all the time. I did that many times. So it's very very
I
possible.
want to be a fast, and it accidentally done.
Okay, no, I like that. No, try to be fast, but the right answer, right? So I just want to make sure that's clear. Okay, and if it's not clear, we have to talk about next question. Ooh, Dopamine took the lead. Which drugs are FDA approved for drugs? Drugs, not one, right? Hopefully I keyed in correctly. So we know that is the treatment that you most likely see as EMDR, but there are drugs that are approved secondary treatment for PTSD. What are they? Right. If this is not on your test, it might be good for practice. I mean, for real clinical scenario. All right, so this was drugs. Good job, everyone there. You guys did excellent here. Complicated question, right? I did cover this in the course, but not in so much detail because I want to focus on EMDR. Now, let's talk about when personally I prescribe one versus the other. Okay, this is my preference. It is not scientifically based. There is some research to suggest if I have a female that was traumatized, especially sexually, I go preferably with Zoloft. Okay. Now, in practice, I have seen a lot of practitioners working on the prisons, and they like to prescribe Praxil. Praxil is excellent drug, but in my practice, I've seen that it causes extreme or more than others, at least in my view, sexual dysfunction. So there is a reason they may give this in prison. I don't know, but I prefer not to use Praxil myself, just because of the strong correlation with sexual dysfunction, right? So now, if you encounter a male with sexual dysfunction, and if it's healthy, and if it's appropriate, you can add a 50 milligrams Viagra. Okay, that'll probably solve the question. If that doesn't, let's go ahead and add Buspar to it, right? Or if the Zoloft is too high or Praxis is too high, go ahead and start decreasing by 25 if it's Zoloft, or 50, depending on what's the dose. So what you want is find the balance. Alternatively, depending on any symptoms, you could add Wellbutrin. So basically here, I'm countering the serotonin versus the dopamine and norepinephrine. Not only am I countering, I am also decreasing the side effect of the serotonin, but I'm also improving the mental health by adding norepinephrine, dopamine, depending on the drug that I pick, right? Remember, Wellbutrin doesn't have, in theory, sexual dysfunction because it does not have serotonin. Okay? Now, are there all? No, there are many other tactics that we can use. Let's say that the person is skinny and can't sleep. Then my choice would be mirtazapine. I'm increasing the appetite, and I am decreasing the serotonin. Preferably at that time, I would wean off the Praxil and go full on mirtazapine. Okay, so another one for mirtazapine, it doesn't cause the vomiting feeling that patients usually have, especially on the first, second week, right? So in the psychopharm, we'll break all medications, or at least most of them, or all the ones you need to know by excruciating details. It can be painful, but I promise you, if you finish, you will feel super ready to take on and have any challenges ahead of you and be like, okay, I got this. I know this drug does X, Y, and Z. I know this drug has all these receptors. So I'm going to do this combination. And I kind of really feel comfortable with the results that I get. Okay. All right. So next question. How long can someone display psychotic symptoms and be diagnosed as schizoform instead of schizophrenia? What's the difference between schizoform and schizophrenia? All right, we have 15 seconds to make your answer. All right. So what is a brief psychotic? Well, let's put it this way. If you, in practice, okay, not for the test. So a patient comes to you, he is 25 years old, male, complaining of hallucination, disorganized thoughts, difficult movements, and delusions. This has been going on for the past 2 weeks. Which diagnosis would you give this patient? Is it schizophrenia, schizoform, brief psychotic disorder, or most likely the effects of drug abuse?
Brief psychotic.
Brief
Brief
psychotic.
psychotic, right? Because why?
It's been less than a month.
The time frame.
Perfect. So that's for practice, guys, because I don't think the board would ever ask you stuff like that. Because in order for them to ask you stuff like that, they got to give you a complete scenario, right? They can't just say it. But the point that I want to make to you is that as a new practitioner, you don't want to jump into, oh yeah, schizophrenia, because our mind goes straight to what we see most. We don't hear too much about brief psychotic disorder, but it cannot be schizophrenia, especially for charting, especially for insurance purpose, right? Not for the board. The board will never give you a clear-cut scenario with everything is in there by the book, unless if it's a GAD. The GAD diagnosis, they have to tell you that it's 6 months. Okay, that's an exception there. But everything else is, they don't give you 100%. They don't say, hey, this is a major depressive disorder with over 2 weeks and 5 symptoms, right? And those symptoms are not due to medication, other medical conditions, blah, blah, blah. They have to give you everything in order to go by DSM-5, because it can look like something and not be that. It can be, another reason due to labs or low testosterone or high or low cortisol, right? Anyways, so here, don't jump into schizophrenia because it looks like schizophrenia in real life. It can be a brief psychotic disorder. we'll also do a rule out for drugs, right? Now, remember why I picked 25. What is the peak age of breakthrough schizophrenia for males? Very
19,
important. Say it again?
19, 12,
18 to 25.
Perfect.
19 years old.
Yeah, it falls into 19 years old, but the broad is 18-25. Now, what's the peak age for females?
25 to 35.
Perfect. Why is it important? If you get a male that's 45 years old, accompanied by the family member, and say this is the first psychotic break, as you get the report from the ED, you would be very likely to ask for not an MRI, a CT scan, just to look out for a tumor, or first action would be collect labs to see if this is a CPC or other drugs that's causing the symptoms. My point is, it's unlikely to be the first breakthrough at 45 years old. Now, I see a lot first breakthrough because that's the population that I work with, 18 to 25. Never had any problem with them. Boom. Now become disorganized thinking, hallucination, paranoia, and so forth, right? But the age is important for schizophrenia. You need to know 25 to 50, 18 to 25, 25 to 35 female, okay? And also for practice. So amphetamines are approved for children of what age? Remember, there is only one age that we highlight in the course. That starts with 3. I think I answered right. All others really start with 6 and above. Perfect. This information you need to know, okay? Amphetamine, 3 and up. All others, really 6 and up. So, what are my other options if I don't want to use a stimulant for ADHD?
Guanafacine and
Guanafacine.
Clonidine.
Guanidine.
Okay. So there is one more.
Strattera.
That's there. Okay. All right. Well, what are if you have someone that is suspect of drug abuse, but you still want to use a stimulant, what would that be? Okay, let me pull this back. Which ethical principle would allow me to, I'm coming back to the question. Which ethical principle would I be using if I withhold a medication due to possible drug abuse?
Maleficence.
Do not.
Maleficence.
Mhm.
Write that down. If you haven't heard, that's important concept.
What is that?
Maleficence.
Oh, yes.
Okay, important concept. We covered this yesterday. Now I said, you know what? I'm going to give this guy a trial. He really seems that he would need it, but I'm going to be cautious. Which medication, if I still want to do it, would I likely to use that is a stimulant, but it has a less likely chance of a drug abuse?
Vyvanse.
Vyvanse.
Benefits.
Excellent. Whoever said that, excellent. Vyvanse, right? Why is Vyvanse less likely to be abused? It's still a stimulant. How does it work? Okay. So Vyvanse, right? Like if I get I don't know. I don't know too much about drugs, how they use it, but if like Adderall, break it, snore it. Maybe some people would be crazy to inject in your veins. That would be like extreme crazy, but I wouldn't doubt that could be happening. I'm pretty sure it's happening, right? Now, if I do the same with Vyvanse, it wouldn't work because it has to be, there is an enzyme that has to go through. Remember, if you're snoring, you are going to go a direct route versus if you're snoring or if you're injecting, you're bypassing the first pass mechanism. And also Vyvanse, you need to be, in order to get its effect, it needs to be digested. Okay? So it's a choice. Not saying that it couldn't be other ways to go by and bypass that again. You know, we make a counter to a problem. We count the problem and they counter that problem. It's like, you know, it's like when I was in Iraq, we didn't have armed trucks. Then we started making armed trucks. What they did, making bigger bombs. It's always like that. Okay. So same thing. We make a drug to bypass a problem, but they will find a way to bypass what we did to circumvent the, you know, illegal or inappropriate use of the drug. All right. Next question. All right. So metafenidate are FDA approved for children of what age? All right, we have 43 seconds, 42 seconds left. Pick your answer. Okay. We have to distinguish between metafenidate, 6 and up. Amphetamine, we just saw in the previous question, 3 and up. These kind of easy hanging fruit, because it's memorization, or either it is or it's not, it protects us versus those wish-wash questions that we could get wrong because we misunderstood, but we cannot afford to miss facts. Okay? Memorization. Clonidine and guanfacines are FDA approved for children of what age? I see some fast test takers here. Oh my God. Wow. In the same concept that we covered, right? And this is what I love about you guys. You know, some of you guys are embracing. You know, you're not just like, I want to pass. You're taking the hard road of learning, of discover, and really enjoying the process. The passing the board will be the consequence of your studies. Okay? So it will come. I promise you. It will come.
So, Dr. Lopez, mine 6 is mine. But my thing disappeared. 6H plus 6. I don't know.
Oh, I
Wanted
yeah, sorry. I
I
cahoots.
don't know.
I can't help on that one. Anybody else
Yeah.
had the same problem? No, right?
So,
Okay. So remember, it's easy because it's only amphetamines. That's 3. Everything else is 6 and up. Okay. For ADHD type medications. Right.
Which two did you say are 3?
Amphetamine. The first question that we had like 2 questions ago. Which drug should be discontinued if ANC is above 1,000 and or WBC count is less than 3,000? A bit confusing here, right? So it should be if ANC is less than, not more than. Less than. Correction.
No.
Okay? But even if it is as the question states, you can still use the WBC count, right, of less than 3,000. I would discontinue still. Okay? So usually they'll ask about ANC, but the WBC counting overall less than 3,000, it is concerning. Okay? So with those types of questions, anyone use carbamazepine or what's that drug?
Clozapine.
Clozapine. Start sneezing. Just feeling a little bit tired. Just kind of wanting to go to sleep. Not even having a fever yet. Just thinking about it. Go ahead and discontinue. So the questions will be things like, everybody knows you know A and C, so why would I ask that on the test? Really? What I would ask if I'm making the test is, John, 35 years old, came in for X, Y, and Z. Now he's taking carbamazepine. After 3 doses, he started having a light fever of 100.05, 100.5. He's overall feeling okay. Family is along his bedside, and I'll fluff the question, right? Which of the following actions should you do? Continue the carbamazepine and monitor labs closely, right? So I'm giving you something, and then I'm reinforcing that that may be a good answer, right? The other answer would be discontinue carbamazepine immediately. And I don't say why. That's for you to figure out, right? So what I'm saying here to you is that the questions may be blended with the patient's fine. It's just a 101.5. Nothing else is wrong, right? But for you, immediately discontinue the medication. Okay, discontinue the medication. So in overall, when the tests, all the questions really, that seems to be okay, but it's just one little thing wrong, be very, very aware of there is a hidden reason behind. For example, John started taking amphetamines, improved grades, doing well in school. Life is just the best possible way. But he started having a mild tweak. Anytime you see something out of the blue in a question, doesn't even belong there, watch out. There is a hidden secret behind. There is a reason we introduce one fact that doesn't even go with the question, like a fever, mild fever, but otherwise feeling okay, there will be a rationale behind it that you have to be aware of. So if you ANC or either carbamazepine, right, possibly, and have any fever, malaise, any night sweats, anything that may indicate a fever or indicate infection, you have to stop the medication. And it will not be a hardcore infection described on the test. Okay? It'll be just out of the blue, like sneezing or throat. Throat is a good one. You know, asking for lozenges because his throat is itching, right? Things like that. It could indicate infection. So otherwise, feeling okay, always for every question, doesn't matter what it is, start a treatment, doing great. Otherwise, X, Y, and Z is happening. But other than that, no other problems. Watch out. Okay? All right. Bummy is on fire that 3 in a row.
Dr. Lopez?
I 1 second. I will answer your question just a second, please. Okay. All right. We'll go back to this question. Just 1 second. There was someone that had the question before. Can you please ask your question?
Yes, no, I was just trying to log. It's saying that somebody has taken my nickname. The nickname it's not allowing me to log in.
Okay. Can you use another one and pick another name there? I guess.
Okay.
Do you have a login PIN code?
Yes, I wrote it down somewhere. Yeah.
Okay. All right. So again, this is raw memorization. Unless if you're not in a course, and I get it. If you're not, then you got it wrong. But if you are in the course and you got this question wrong, I need to know. I need to know how I can better explain this question to you.
You can remember this really easy. Carbamazepine.
That's it. Carbamazepine is in one way. Or you can do the 3 A's. What are the 3 A's for carbamazepine?
A granular
Granulocytosis,
and a plastic anemia.
plastic anemia,
And what's
Asian.
that Asian population? So please, if you are in my course, and if I didn't do a good job here, you gotta let me know so I can help out better. But this is in my PDF, and this is in the videos, and we covered this on live course, right? So what I'm trying to say here is not you, but it's me. How can I help you better? And the only way I will know if you let me know. Okay, so if you got this question wrong, maybe it was your finger too fast or another reason, that's okay. But if it was a knowledge problem, I need to know because we covered this in detail. But if it's not that clear, I'll make more questions to make it even more clear. I'll repeat it more times. Okay, just let me know, please. You can email me or call me or text me. Okay, I'm very approachable. I'll answer your question, so no worries. Which drugs act as an inducer? Ooh, that's gonna be hard, huh? So inhibitor, now inducers. Okay. Right. So carbamazepine is a potent inducer. I'm very proud of you guys. This was not a necessarily a easy question, right? You had to memorize your acronym to get this one right, and it was out of the blue. So good job, everyone there. Not an easy question, right? Because this is like a top level memorization, but it's a very potent inducer. Now, if you want to take a step ahead, out of the blue here, what CYP would carbamazepine be? Very hard, right? All right. So carbamazepine is a
PA4.
potent
Four.
inducer. Yes, good job.
PA4.
3A4. Yeah, 3A4, right? So it's actually a very, the reason why I personally don't like carbamazepine is because it's like it gets its hands on everything else. What I mean is it pretty much affect all of the drugs that you are using, right? It either sometimes increase other drugs by 50%, sometimes it decrease other drugs. So I personally prefer not to mess with it because it will have drug to drug interactions, right? Yes, it's a 3A4, and it has a significant speed up of the metabolism of other drugs that are also metabolized by this enzyme. So it really complicates things as far as treatment if you are using several drugs. Now, does it mean you won't have to deal with that? No. If your patient is taking carbamazepine and is stable, now it's on you to keep up with the treatment, right? I'm just saying if you have a choice, maybe you're wise not to mess with it. But if you don't, the patient's already stable and you arrive to the hospital and you're taking over today's shift and you are on for the next 7 days and off for another 7 days. Let's say that's your schedule. Well, you're going to have to deal with that patient and that medication, right? Hopefully, nothing will derail. But if you do, you know how to do it. Which drugs may be less effective if taken with carbamazepine? Understand the concept that we just talked about?
I know it, yeah.
Okay, so we know that carbamazepine is the inducer, right? and it can, we cover this in a course as it can affect valproic acid in making less potent, right? So it has this relationship that will make it, it can affect, make it less effective. So can decrease valproic acid, the faster metabolism results in a less concentration of valproic acid, right? So we have to be aware. And some books will even state of up to 50%. So now think about it. If you have carbamazepine and then you decrease valproic acid by 50%, you're likely to destabilize a patient. They might now have a manic patient, and you're wondering what happened. Okay? Very complicated, guys. When you start prescribing, you are dealing with precious life. You are dealing, with a population that's vulnerable. And sometimes they cannot even defend themselves. So we have to be very, 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 very good on what we do so that we cause no harm. Okay. I know passing the board is where we are today, but as we progress, there is more things that we have to be much more aware of and conscious of our power that we carry as providers. Okay, we have a sacred duty to take care of others. Okay, so we cover this in a course. What would that be? A little kid with elongated head. I ask, it also look like other conditions.
Olha aqui pra você ver, ela não pode estar aqui em cima, ela tá lambendo os rapazes,
Ela não tá vendo. All right. So fragile X is the condition here, right? I had the picture in the course of fragile X, makes it a little bit easier. So I also said the fragile X, to me, I have to be careful not to confuse it with the other condition. And the first thing that came to mind is this condition here, right? But if you see on the test, elongated head features, small stature, think of fragile X. Okay, perfect. Down syndrome, right? You guys are fast. Wow. So don't be surprised. You see like some questions that doesn't necessarily apply to psychiatry, like some of the diseases or conditions, but you still should have knowledge of. Perfect. This is a good example, right? Alcohol fetum syndrome. So great job there, guys. Oh yeah, Kaya got the lead. Jill, congrats, Jill. You know you passed the board. Doing great.
Thank you, sir.
A patient with Depakote level is 23. Ooh, it's a hard one. But we covered this a little bit in the course too, right? On Depakote slide, we said, hey, if Depakote is more than X, Y, and Z, it is too much toxicity. These are what we're looking for. All right. So when we say Depakote, right? Depakote is not only for bipolar condition, right? It can be used for seizures. So that's why I say that that you could encounter a patient that is on carbamazepine and you didn't put the patient on carbamazepine, but there was the neurologist. But now it's dealing with your medication. You have to know how to adjust. Now, valproic acid or Depakote can be used for seizures, more likely to be used for seizures than it is to be used, more commonly used for seizures than it is for bipolar, because we have more people with seizures, right? Bipolar disorder, migraine headaches, I could use Depakote as well. So it's a, a large, not a large, but a lot of conditions that I could use Depakote for. Now, if you look at the blood, we want 50 to 125, ideally, right? Does that mean if it's 130, 135, I'm going to discontinue? No, I'll watch, right? But ideally, by the books, if it's over 125, you really want to stop and hold, or at least monitor, see any side effect, immediately stop. Okay, so if it's 23, now we know it's low. It's less than 50, 50 to 125. Okay, so good job. Now, if it's Depakote, what are the FDA warnings for Depakote that I should watch out for? You should know all the FDA warnings. Usually, I don't go in details for medication because it's not important. But FDA warnings, super important. What are the FDA warnings?
Hepatotoxicity and pancreatitis.
Perfect. Okay. All right. Yeah. So great job there. And you need to know what do they look like in real life, right? Not only for the board, but for the board specifically, but for life too. Okay. Life interactions. Okay. Great job. You got 100%. So I said the normal is X to X, X to Y. Okay, perfect. Well done. 50 to 125. Normal, 50 to 125.
50 to 125 keeps you alive.
Mhm. Mhm. Okay, so excellent here. How do you know if it's toxic or super therapeutic, right? So what, if I say, hey, it is 130 or 135, I'm inclined to say this is super therapeutic, right? So we just need to assess, monitor, collect labs more often, or decrease the dose if the patient's not in the hospital, right? Because I don't want to keep increasing. But there is a difference between toxic 163. It's pretty high, right? It's pretty out there. I should be concerned at this point, very concerned in life, right? I'll be like, oh, I'll be driving to the patient's house, taking that medication away. No, not really. Um, Lithium. What's the right lithium volume?
0.6 to 1.2.
Okay. If the drug comes back at 1.4, what do I do?
Monitor.
Monitor.
Monitor. Just monitor. But now if you're monitoring and you see, you assess side effects, then what do?
Discontinue.
Just continue. Very important, guys. You do not discontinue the medication, lithium, if it's 1.3, 1.4. Now, if it gets you 1.5 at that range, I would discontinue the medication, even if the patient is asymptomatic. Right? So 1.3, 1.4, assess. Symptomatic, discontinue. Asymptomatic, continue the dose. Check the labs again, 1.5. At that point, discontinue the medication. And then collect labs. You don't collect labs first and wait. As you get the lab, obviously, or if you know of the results as 1.5, you have been given report is 1.5. At that point, you discontinue the medication and ask for a new lab. Okay, so you don't wait. Your action is not to wait for the lab's result. You take action and confirm. If you're wrong, it's okay. The patient's not going to die. But if you're right, you could be saving a life. Okay. Lithium has a narrow therapeutic range. It's not like Depakote, 50 to 125. Lithium is like very little. Okay. So we cannot mess up lithium at all. Oh, here you go. Just give the question away, huh? Okay. So I thought I just covered the subject. Maybe it was um people are still not understanding the concept of super therapeutic, meaning above what we would consider normal levels of any medication. But with lithium, we don't have to go very far from 1.2 to 1.6 is a very small distance. Now at above 1.5, I discontinue. This is toxic level. If I continue to see my patients at 2.5, I am very, very, very concerned. The patient may die, toxicity, right? May have seizures, may have undesirable outcome above 2.5. We don't have a whole lot. And this is why, if lithium is the drug, the gold standard for bipolar, so why some people don't start it right away, right? Because we can now raise the level of lithium fast. But I can do it with Depakote. Then I start the patient Depakote, inpatient. As I transition, I stabilize the patient, then I transition to outpatient with a recommendation of monitoring lithium level and starting lithium levels, okay? But I'm not going to keep the patient in the hospital until the levels of lithium is appropriate, so I'll start with Depakote. All right, I think everyone got this right. All right, we got 35 seconds left there. Perfect, right? I trust that this was a fast finger. So let's, just in case.
A super
let's
fast
call
finger.
Yeah. So I trust that that was it, right? Because, guys, lithium level is what range?
0.6 to 1.2.
So 0.6 to 1.2. Now your lab comes back 1.3 or 1.4. You assess the patient. Patient has a symptom, you discontinue the patient. I mean the drug. Patient has no symptoms, you continue to monitor the patient and do not discontinue the medication. 8 hours went by, you check the labs again. Now, the patient does not have any symptoms, but his level is at 1.5. Your action at this time is to stop the medication. Okay, so it should be no confusion about these levels. Now, if your patient comes back and his lithium is 0.5, you know what to do, right? So, okay, moving on. If you guys have an issue understanding what I'm trying to convey to you, please stay back at the end of this course so we can try a different way. What are the 3 A's for carbamazepine? Right? So it should allow you to do 2 answers here, right? If it doesn't, then it's my fault that I didn't do the question correctly. But it should be 2 answers, right? For this question, pick 2 answers. Perfect. Now, if I say hypotoxicity and pancreatitis, what medication are we referring? Say it again?
Valproic.
Valproic.
Valproic
Okay.
is
The dipic acid of valproic. So please know these 2 medications, these 2 FDA warnings, very, very high yield. Okay, so good job, everyone there.
So y'all said for Depakote is hepatotoxicity and pancreatitis.
Yes.
Okay.
And you need to know in detail what hepatotoxicity looks like. We'll cover this next week on the crash course review again. But you need to know in detail what hepatotoxicity look like, and you need to know in detail what the pancreatitis look like as well. Not just that pancreatitis or hepatotoxicity, because you need to distinguish and what to do thereafter. So this will be covering detail next week as well. Okay. Should be a 2 answers. 2 answers question here. I don't usually do a lot of 2 answers, right? You gotta pick 2 drugs. Or 3 if you want to, I guess. Or 4. But at least more than 1.
No.
Perfect. Okay. Good job, everyone. So agranulocytosis equals carbamazepine and clozapine. Those 2 drugs are associated with agranulocytosis as possible unwanted effects. Right? Drop your A and C down. This one's a hard question, right? You may have covered, but not in a whole lot of detail. All right. So actually, SNRI is associated with that, but it's not only SNRIs, right? So we have other drugs like chemotherapeutic agents are also associated with that. Remitics drugs that's used for treating irregular heartbeats are also associated with that. Let me see, immunosuppressive drugs also has an associated with that. Now, as we mentioned here, SNRIs also are associated with that. Now, always remember that the reason why we don't give TCAs as much as we give SSRIs is because SSRIs are safer. If one takes one bottle of Zoloft versus one bottle of TCA, the Zoloft most likely will have explosive diarrhea and stomach upset and a massive headache, when the TCA most likely will affect the heart and could cause fatal incident, right? That's also high yield. So some people might be saying, just want to go back to the previous question about the lung disease. So some people might be thinking, hey, if it causes this, why should I use it? Well, let's be very, very clear here. SNRI, can you hear me?
Oh, sorry, I just unmuted my mic for a moment.
Okay, so let's be very, very clear. The previous question, the chance of getting a lung disease due to SNRI is very, very low, right? So there have been cases report and very, very few studies that cover that. So could be by chance. Now, realistically, very, very low chance. Most importantly, the benefit outweighs the risk, right? And as providers, we have just to be aware of it and monitor. It should not be a reason to stop you from prescribing any drugs because it could cause X, Y, and Z. We still prescribe, also is dopamine antagonistic or D2 antagonistic, right? So we prescribe and we shouldn't be worried about causing TD as the main reason for not prescribing. We prescribe, we monitor, we use our tools in psychiatry, and at first sign of a possible problem, we make adjustment. You shouldn't say, oh, because I'm prescribing this drug, I'm not going to because I'm worried about. Yes, you should be worried, but at the same time, you should know that the percentage of those cases that have those side effects are not very high either. So urinary incontinence is possible side effect of which drug? Antipsychotics is also a possibility there. It's a hard question. Very hard. Okay, this is a hard one, right? Because really, all of them actually could. So sorry, I should have put in all of them, right? So all of them actually could cause um, the unwanted side effect of hyponatremia to begin with. So it's not correct that so only citalopram and duloxetine. Actually, all of them could really cause that. So paroxetine, citalopram, duloxetine, and citalopram can potentially cause hyponatremia, right? Which is low salt, sodium, right? So all of them should have been the right answer. But if you ask SSRIs, right? Paroxetine, citalopram, and escitalopram are more commonly associated with the side effects than SNRIs. Okay, so I just want to clear up and make it more understood. The question was not giving you a true answer, right? So all of them, it would be the answer. Most likely, citalopram and paroxetine, more so than duloxetine, SNRI. Okay. A tricky question here, huh? Very tricky. How can a drug cause mania, depression, and psychosis? Perfect, guys. Very proud of all of you guys there. Excellent job. So remember, when we say steroids, right? The test will almost never use the terminology, but it's up to you to know that prednisone is classified as steroids. Okay. Good job. Very good answer here. And oddly, it could cause depression, mania, and psychosis, right? So be careful. You have a patient that is stable and now has been prescribed a prednisone, and the answer will say things like the new medication is an inducer, the new medication is an inhibitor, when it has nothing to do with the inhibitor or inducer. But we know that most students straight goes to inducer as an inhibitor. I don't know what's out there, but people immediately think this is an inhibitor or inducer case when it has nothing to do with that. It has to do with the other medication being added and cause potentially depression. And now my patient that has been stable, good example, Accutane. I got called maybe like 3 weeks ago. The dermatologist called and said, hey, X, Y, and Z, I'm starting Accutane on your patient here. Just want to give you a heads up. He's not going to tell me in detail the reason, right? It's up to me to know, and I am very thankful that he did that. So what I do, I'll raise my dose a little bit to counter his dose, all right? so that my patient that's stable does not become unstable. Somewhat of a hard question because you could use true.
Is that borderline personality disorder or bipolar
Yeah,
disorder?
borderline. Lithium, right? All right. So I'm not gonna. I'm not gonna. This is covered in a course. Okay. Now let me see what's the other question before I spoil. Okay. I wanted to distinguish the two medications that we use for borderline personality disorder, depending on the symptoms. Right? We cover this in a course, okay? And we'll cover again on the crash course review next week. And by the way, if you are working or if you are in school or whatever it might be, if you are off specifically, please try to come to the, it'll be about 7 hours. It will be a long day. So you should sleep late. So we're going to start a little bit all over the night. But come because we can address some issues.
How do you register for that class that's going to be like 7 hours? What you're talking about?
Oh yes, next week, stay put, and then I'll give you the intel at the end of today. So basically, you have to go to our website, www.npexamcoach.com, and enroll in the crash course review. We'll talk a little bit more about that. What is the medication of a choice for a patient with borderline personality disorder with depressed mood, emotional liability, keyword here? And by the way, anytime you say emotional liability, you are talking about a mood disorder. And anytime you hear that word, doesn't matter if it's kids or adult, you want to give a mood questionnaire. High yield, guys. This is high yield. Every time you hear emotional liability or mood swing, but especially keyword here is emotional liability, you want to give a mood questionnaire, not a PHQ-9, right? Mood questionnaire. So specifically, how to decide lithium, aggression, specifically, or self-harm behavior. Everything else, especially depressed mood, mood liability, DEPA code. Okay? Very high yield too. All right. Wow, guys, so proud of you guys. That's a hard question, right? And actually, I didn't even tell you to pick two medications, and you guys really killed it. So really, um, really cool stuff. Now, will it fix it? The problem to, in the case of make it no longer existent? It will not, right? It will counter the symptoms, but it will not make Tourette's disappear, right? So when we say uh, we can use Abilify, we can use Haldol, right? Just remember, Haldol is the typical antipsychotic, which means it has a stronger affinity for D2 blockade. It blockades the D2 receptor at 80% compared to second generation or atypical antipsychotics that blocks the D2 at 60%. That difference between first generation and second generation is what causes the unwanted side effect of EPS, more likely with the first generation. So is the second generation better? Usually yes, but depend for what symptom you ask. In exchange of less EPS with the first generation, you get more of what with second generation?
Dopamine.
5-HT2A.
5-HT2.
Serotonin.
Sure. Let me refine this question.
Serotonin.
Let me restate this question. Maybe I wasn't clear. First generation, you get more EPS. Second generation, you don't get as much EPS, but it comes with another condition that you don't get as much on the first generation. What condition? Group of conditions. Symptoms.
Metabolic.
Yes, yes, very good, very good. So along the way, you guys also answer the question: the difference between first and second generation is the 5-HT2A. Okay, this information is high. Now, what would you consider a metabolic syndrome? How many of those conditions together do you need to have?
We have to check
Two.
the best.
Weight
More than
gain.
two, more than two, right? And it can be lipids,
Abdominal
circumference increase.
circumference.
Okay,
Mhm.
all right. So when you get
Glucose.
more than two, glucose increase, abdominal circumference, weight gain, BMI, hypertension. You could also get lipids
Lipid
increase.
panel. Yeah.
Yep, all kinds of things, right? When you get two of those, would be considered metabolic syndrome. Very critical. Then you do not stop the medication. You continue the medication and suggest exercise because of metabolic syndrome for the board, for real life, really. Do not destabilize the patient that's stabilized. Do I give a stimulant to a Tourette's patient? So if you pay attention to the previous question, you should be able to get this question right.
Sama question. Antipsychotic, antipsychotic version. Oh.
Okay, perfect. So we're getting understanding that Tourette's, we go with antipsychotics, right? It can be Abilify, it can be haloperidol, it can be Primoxide is another one that's FDA approved for Tourette's. Now we're looking to fix the tics, right? Other medications are frequently also used in practice based on evidence or clinical experience, but they are not necessarily FDA approved, right? So that brings the point of off-label, very important for the test, off-label use. You continue to do it and use it, and you seek research if your friend, your colleague is using. You don't tell them to stop. You don't tell them it's okay. You look for evidence to support the use of off-label. When it comes to charting, real life and on the board, you have to tell the patients the reasons you're using and inform the patient, specifically document that you inform the patient. Okay, that's for the board too, because they often ask about off-label conditions, right? Don't be tricked on the person that are doing the off-label prescribing is the expert in the United States of that drug, right? Don't get fooled by that. If that comes up, you still want to look at your meta-analysis, systemic analysis, or randomized trial to support or deny, even if it is being used by the expert in the field. Okay? Because experts in the field. Go ahead.
I'm sorry, which meds you said was FDA approved for Tourette's?
There are several, right? So usually haloperidol or Abilify, but also Pimozide is also another FDA approved, and that's PIMOZIDE. Not very much used, but it is also FDA approved for FY. Now my drug of choice, Abilify. Especially with kids. Now, if the kid is extremely agitated and extremely angry or violent, then I'll do haloperidol. But my drug of choice, Abilify. Why? I call it the skinny drug. It doesn't have as much like Abilify, Latured, Acenopine, right? The only thing with Acenopine, you have to put it under your tongue, and it tastes really bad. But yeah, Latude as well. I call them my skinny drugs or my go-to drugs, right? Which non-FDA approved medication can be used for Tourette's. So, all right. So let me make a correction here. Okay. Off-label use for Tourette's. Okay. There are some medications that are FDA approved and some that are off-label. Now, here the correction I want to make is an alpha adrenergic agonistic. Okay, would have been the correct answer. Alpha adrenergic agonistic. So what drugs am I referring to? Clonidine.
115.
So if it's an alpha, let's think for a minute. If it's an alpha adrenergic drug, what class of medication does it belong to? Think about it, guys. Go back, take a step back, just close your eyes and imagine if I'm given an alpha adrenergic agonistic, what does it do?
It mimics the effects of norepinephrine.
Actually, they'll be antagonistic, right? So here is alpha adrenergic agonistic. So we're gonna drop the blood pressure, right?
Correct.
So,
It's to drop the blood pressure, so it's supposed to mimic the effect of the hormone norepinephrine. So therefore, it's used to
perfect.
drop down blood pressures, anxiety, panic disorders. I usually use it a lot in cardiology.
Perfect. So now we are on track here, right? Excellent. Thank you for chiming in. So as a practitioner, you are going to prescribe this drug. So it's part of your education to say, hey, this is off label. This is the class of medication. I should see, right? I should see a possible drop. So it's used for high blood pressure, right? Or ADHD. So education on getting off the bed, not to fall, and things like that, right? So there's a lot more to practice than just say, hey, here's your medications. But anyways, so here we have it. Good job, everyone. So today was an interesting, it was a short questions, right? But we covered a lot part of the exam. So good job, Dylan. Good job. Let me see who that. EH and Tommy. Now we have Kara and Jill. So all of you guys are rock star. All of you guys that came today, that took the time to learn, participate, chime in, help out each other, are rock stars. Okay. So continue to do what you do. Continue to support each other in many ways. Your colleagues, myself, I'll support you. There is always this good relationship that we learn from each other. I learn from each one of you guys all the time as well. Okay. Whether it's to be nicer or whether it's to be knowledge based. So I'm always learning from each one of you guys that always chime in and coming in and helping out. So that's fantastic. Okay. So today event ends for you guys that are enrolled in a course. I'll see you guys next week. So please, 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 please. Next week's going to be long. So how to prepare for next week? Please finish your module 6 on the course. Watch it. Learn it. Dream about it. Write it down. Write it down. Every single word on module 6, which is our crash course review, it's super high yield. So if you revise this and you watch the lecture and you got your PDF, when you come to the live event, it'll be a refresher, right? I'm just talking, you're like, yep, I got it. I know what it is. Boom. You can even put your mic off and talk to yourself. I got this. Boom, 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 boom. It should be just a refresher. It should not be nothing new. Obviously, if you sign up on Thursday, right, it's going to be new. But do your homework. Be prepared for the class so that it will serve you better. Okay? So we understand that there are 5 subjects on module 6, which is our crash course review. So really take the time to learn. I'm sorry?
What's the cost of the class?
So I know it's
there are 2 classes, right? So we have the PMHNP Walk to Success that contains the crash course review. Or you can get only the crash course review plus a diagnostic test. Now, I particularly, people call me all the time. They want to buy the diagnostic test and you're a nursing school. I'm like, don't buy it because you're wasting your time. It's not good for you. I'm not here to sell you something that is not going to benefit you. How would I choose between both? It depends on your time and depends if you already tested. Okay. So why that? Well, if you're a first-time test taker or if you're a second-time test taker, don't go for the crash course review. Really, why would you short yourself with the most important test of your life? Right? It's like it doesn't make sense. You've done nursing school, you went to a master's or a doctor's degree, now you're crossing the line. Why would you ever decrease of your chance of passing the board? But let's say that you've been studying and you just want a quick review and you're taking the board in the next 7 days. Then it makes sense to do the crash course review. One, because it's the most high yield content. Two, is because it comes with a diagnostic test. Also, that's a separate course and we put it together to make it more value to you. But that's the only reason why I personally would choose the PMHNP crash course review over the PMHNP review course 30 Days Walk to Success, which comes with everything together. It's question bank, diagnostic test, complete review of modules 1 through 5, and the crash course review, plus the live and recorded PDF, WhatsApp, you name it, it has it. Okay. We'll talk more about the price in a minute. Let me just answer a few more questions. Sherry, you have a question there? You have to unmute yourself. All right. While you figure that out, let me go with Mary. Mary, are you still having an issue with your question bank?
Yes. I tried it this afternoon. It didn't work.
Okay. So go ahead. It's kind of weird because we've been talking a lot via emails, right? About
Yes.
questions. So I couldn't hear yesterday. You couldn't talk. So I'll go ahead and reset your password immediately after this meeting. So look out for your password on your trash bin immediately after this meeting. That's what I'll do. And you should be able to log in. Okay.
Okay. Thank you. Thank you so much.
Absolutely. Sherry, do you have a question? You have to unmute yourself, please.
Okay, here we go. There we go. I lost the link for. I have the MP coach where I have the
Yes.
the test, but I don't have my where I can study, where I can watch your the course.
All right, Sherry, could you please send me an email, PMHNP at mpexamcoach.com. I'll send you a magic link for the entire course, and I'll send you the link for the PMHNP question bank.
Okay, I do have the question bank already.
So I'll just send you the link, the other link for the rest of the course.
Okay, thank you.
Absolutely. Atia, how are you? Please ask a question. If I butcher your name, I do apologize.
It's okay. I had emailed you before for the code. I was having difficulty registering for the course. And
okay, which code are you referring to?
It was half off, I think it was. I forget. You emailed me back and I tried several times.
Oh, okay. Okay, yes, we talked. Okay, it's yeah. I do apologize. You're right. The website was having an issue. I'm always trying to learn this stuff rather than asking people because they take a long time to fix it. So it's fixed now. So if you prefer to email me, or you can go back and use the same code is working now.
Okay.
All right.
So I'll get the same.
Yeah.
Okay. When
I'll
does
open the code immediately after here. I'm gonna open right now. You can use the code and get your 50%, 40% off.
ask when does the first when does it start? Immediately?
So we don't have a start date. So basically, you can start like with us on. I think actually it's a good idea because you've been studying a while now on your own. So you start for the
Yeah.
module 6,
Okay.
where we're going to meet live. Where we're going to meet live. Well, let's put it this way: you're going to log in. Your first test is to take a diagnostic test. It's 175 questions, 3.5 hours, just like the real deal. Now, if you score 80 or more, then we are going to skip modules 1, 2, 3, 4, and 5, and we are going to concentrate on the diagnostic test or the crash course review and question bank and set you up for a test date because you're good. We're going to bypass a lot of things. Now, if you don't score 80 or more, then do modules 1, 2, 3, and 4, the crash course review, and all the question banks. Because that way we know, like, depending on what your score is, it will dictate what I would suggest for you to do. Right? Because if you already know the stuff, then there's no need to go over again. And your test will tell you. You know, it's very unlikely if someone score 80 on the first time and not pass the board. Very, very unlikely.
So should I just review first? I haven't been studying.
No. Take the test because the test will set you as a baseline where you are, and then now it will be an eye opening for you. Oh yeah, I'm doing good. I can just skip to the diagnostic test. I can skip to the crash course review. Or like, oh no, I got I got a 50. The average is 50, right? So I got 60. I need to really do this right in the right way so I can do once and pass the first time, right? So it's very important that we don't skip steps. There is no magic bullet. I'm not selling a magic bullet. There is work to do, and we'll work together and get it done. Simple as that. Okay? So we don't want to skip steps. But now, if you take the test and you score super high, I definitely think you should skip. It really depends on your score.
Okay.
Okay. But yeah, so basically next week we'll do the PMHNP crash course review. And after that, we'll start again on module 1, 2, 3, 4, 5, and 6, which is again the crash course review. So every week we meet live twice a week to discuss anything. Meanwhile, the whole course can be done on your own through our recorded lectures and forums and WhatsApp group and all the other good stuff that we have, question banks and all that. Okay. All right. So please, if you don't have the code, email me. Okay.
Okay.
Thank you. OP, you just enrolled yesterday, right? So the day before? Believe? No. Luandia, you have to unmute yourself if you have a question. All right, so I'm going to put it here. You can go to, please ask your question if you unmute yourself. I think she's trying to ask a question, but meanwhile, let's go ahead and get Nadinia. Are you trying to ask a question, or is just a hot mic there? All right, let me mute you here. All right.
I have a question.
Yes, please.
So my question is, I have about like 9 months to finish the program. Are you willing to do like an extension?
Yes. Listen, whatever you need from me, you got it.
Oh, okay.
That's simple as that. We'll try to accommodate any situation, anytime. This is really more of a community building than it is more of a business model, right? When people are in business, they don't necessarily give you the time. They put you in a Zoom meeting and say, hey, this is what you get. If you want to attend again, go ahead, pay again, right? This is not it. Promise you, this is not it. We have to cover costs. I have 2 employees, a website, and things that we have to do. But our goal is not necessarily to, like make money per se. We're really trying to help the community. So to answer your question, it's 6 months is the timeline, but I will extend it to 12 months for you. No problem. Now, I want you to do it better than that. Okay? So how would I do it if I was in your situation? I don't think the PMHNP crash course review is the right choice for you. And the reason is that you have time. So let's use that time to make you the best practitioner ever. Do the psychopharmacology course, because while you are in school, you can put out maybe like 2 hours a week and really get your medication to the highest level. And then worry about the board later, right? I think you're too far out. You're not wrong. I took my board 9 months before graduation. Okay, I took my board September before I graduated. You can do that if you have a lot of hours and if you have completed the requirements. They will not give you the certificate. They'll say you pass, right? You only get your certificates once you graduate. But I think for you, the best would be really focused on psychopharmacology since you have the time.
Okay.
It's not bad. And that one is a year too. But I will, if you do it now because of the school, I can always prolong it to 2 years and not a problem. So we'll try to help you guys out as much as you need. Okay.
Okay.
So if you go to PMHNP, www.npexamcoach, go ahead and use, Karina, what's the code that we have right now? Do you know? For 1 second, please. Oh, never mind. Let me search here for a code for you to give you a discount. Go ahead,
It's
email
now,
me.
Dr. Lopez, now.
Now, okay. So I don't even know what we have out there. You can use the code now and get a nice discount on that. So yeah.
Now, as in NOW?
Yes, man.
Okay. Thank you.
So you can get a very nice discount. Let me see if it works because I haven't really looked at that well. I think now is the discount code.
Hi, Dr. Lopez. I was
Hello
trying to
there.
mute myself earlier, so I had to log out and log back in. I don't know what was happening. So I was gonna ask in regards to the crash course on Friday. Do we have to do another registration for that?
No, if you are part of the PMHNP, 30 days walk to success, it includes the crash course review. So it's like I added 5 courses in one, so you don't have to pay 5 times, right? So some people, what they do, shamefully, in my opinion, they'll say, here is modules 1 through 5. Pay $400. Here is the LMR. Pay $250. Here is your question bank. Pay, I don't know, $99. I don't know what that's just not cool, right? Why not do one course that covers everything and be upfront, right? In my opinion. So maybe not business-like. Maybe if I wanted to sell more, that's what I should do, right? But that's not it. So we put it all together for you. So that way you get the best possible chances of passing and you don't short yourself short, because it is the most important test of your life. So it makes no sense to kind of like go easy on it. So in my mind, but now some people may want to do the just the crash course review, and that's totally fine. It depends on the person situation, right?
So on Friday, we're gonna get a link in our email.
Yes.
Join. Okay.
We'll send the link twice. We'll send the link usually on Monday and on Thursday. We'll also put the link on our forum. On our course, there is a forum there. Some people use it every day. Hey, today I learned X, Y, and Z. Today I learned the carbamazepine has 3 A's: agranulocytosis, aplastic anemia, Asian. So some people use it very effectively to rewrite what they learned for the day. And some people use the forum to ask questions. But don't forget that we have 2 ways of doing this. We can ask questions immediately on our WhatsApp group, or we can go to the forum and ask questions there. And if there's a problem with login, can't get here or can't get there, email me. Don't put on social media, because I have 20 different posts or locations on social media, and not all of them are monitored. I can't help you if I don't see it, okay? So, let me...
Dr. Lopez, just
please.
an FYI, the code does work. It has to be capitalized, NOW.
Oh, okay. I
Okay,
think...
and it does work.
Thank you. I think it depends where you go. Yeah. So it depends what link you use, because it's complicated, guys. I wish to always make things easy, but I have my main website and I have a coursework, right? So both of them can take orders. So if you go to the main website, which I'm going to do it now, or I can look at it, and now it's not working, but let me see what kind of coupons I have there. So, and I'll put the link here in the chat box for the Psychopharmacology course and for the coupon for the 30 days Walk to Success as well. So whoever wants to sign up today, you can do it. Now, if you want just a crash course review, it's okay. That's $199, right? And it comes with not only the crash course review, I also added a diagnostic test. If you don't score more than 80 on your diagnostic test, I would highly recommend you to not test. Okay? You'll be in a very difficult situation. If you score, let's say you did a crash course review, you chose to do that, you watch the lecture, and you study. Your test is in the next 7 days. And you take the diagnostic test, and you don't score more than 70, I would not test. I promise you. Now, if you score between 70 and 80, you could do some adjustments and possibly test. If you score more than 80, I would absolutely test. Okay? So let me put the link here for the PMHNP crash course review, if that's what you want. That's an option. That's why we give it, right? But I think I want to just highly recommend you to only take this option depending on your time. You're already testing very soon, right? Because in my way of seeing it, it's the most important test of your life. You may not want to shortchange you, in a sense, right? Should go all in one time and done, so I don't have to repeat it. The thing with repeated tests, if you tested once, you still have a good chance. If you tested twice, your chances now are very, very low. And this is why I enforce, don't test it until you're ready. Oh, I've been in for 3 months. Yes, but have you been putting the time? Have you actually doing the material? That's important. Some people do it in 3 weeks. Some people need 6 months, and it's totally okay. No difference. As long as you, when you walk in the test, you know that you will be PMHNP and board certified. Okay? The time, it doesn't really matter. We just got to do the work.
So, Dr. Lopez?
Yes.
So are you saying that for I haven't finished like I just started like module 1 and everything. I shouldn't do the crash course on Friday? Is that what you're saying?
Well, if you go to the upper left corner of your screen, you will see something called all trainings. Why do I hide all trainings? I don't want to freak you out because there might be 100 trainings there for you, right? I just want you to see one by one so that I'm working with you on focus on one by one. However, because we are going to do the crash course review, I think you should jump to module 6, watch it, learn it, really live the moment on learning, and then attend the crash course review. And guess what? The week following, we are going to go to module 1, which will be perfect. By then, you probably be on module 2 already.
Okay.
So
Yeah.
does it make sense?
Yeah. And secondly, you know, I paid for this thing and I sent you an email. You said you're gonna forward it to the psychopharmacology course. So I just want to find out like how much balance I'm supposed to pay and also get the link, you know.
Yeah.
So because
No worries. Yeah, if you paid any extra, because I think you bought extra stuff that it was already included in your course, so we'll go ahead and either refund you or give you whatever you want. But
yeah.
I haven't looked at my email. Honestly, I just woke up late today, but I will definitely answer to you immediately after here. Okay.
You know, somebody already responded and they said they're
Okay.
going to forward it to the pharmacology course. So I don't know how much balance I'm supposed to pay for the course and if you're giving any discount for the psychopharmacology course. So I don't know all those things. So I really need
We'll work that out. You will get absolutely wonderful discount. So don't worry about money. We'll get the best price ever. So
when does that one start?
you should not touch the course. You should not until you pass the board.
Okay.
Okay? Because it's not for the board.
Okay.
The course is not meant to help you for the board. It will actually probably, I wouldn't say that, it's not high yield, right? So the board will not ask you methotrexate. How is methotrexate different than SSRIs? What's the mechanism of action? Why does it doesn't have sexual side effects, right? So stuff like that is excellent for school. We have all kinds of charts, all kinds of books. I mean, you probably get over $1,000 in prizes extra in that course. You get PDFs, you get medication book, you get Carlet, you get every module. I have a surprise for you. Every module, right? Because I really want this to be the best course ever. So every module, there is a handmade chart of what I think is the most important for each medication. Took years to build that, years. So is it good? Yeah. But is it high yield? No, it's not for the board, right? So if you have a long time for the board, then get your psychopharm tight. Get it like you know what each medication, like you can wake up at 2 in the morning, pick up a phone, and be like, do X, Y, and Z. Go ahead, give 50 Benadryl. He's having like, this is a side effect of the D2 medication. Give 50 Benadryl, I'll be there in 30 minutes. Boom. With confidence, without needing to go to the books, without searching for, This is the level that we want everyone to be at. Now, one thing at a time, right? We don't want to do this for the board now. We want to focus on the board. So we need to do the 30 days or the PMHNP crash course review. Either one. How do you choose? Well, do you have time? Take the 30 days. You don't have time, take the PMHNP crash course review. This is not about the money, the cost, because that's irrelevant at the end of things, right? Sure, it matters a lot, but it's still what matters the most is your outcome, right? It's whether, like I can say, well, somebody comes, do a paint my room and charge me like $300, or I can do it, but is it worth my time, $300? Right? Like painting a room? No, it's not, right? I can go do an interview 1 hour and make 500, right? I mean, this is a fact, right? So why should I be painting my room that's going to take me 8 hours? It doesn't make sense. So it's better to pay, get it done, and I can use my time appropriately. So the outcome that we want is not only pass the board, right? It's have a community for lifetime, by the way. Like those people that passed last year, they all be recognized with additional courses, with the monthly meetings. As I'm getting more organized and getting the time to do that, it's a community building. It's not just a test prep, right? So it's a lot more to come. Now have other projects coming up. Possibly when they get it done, you guys all be the first takers, beneficiary of those projects as well. So, all right. So, Lupidri, if you want to, could you please email me so I can get you a discount correct? My email is pmhnp@npexamcoach.com. Okay. Now, if any of you guys want to do the 30 days PMHNP Walk to Success, I'm going to put a code here in the chat box. I'll give you $150 off. Like, super nice. And this is for the main website, okay? So pmhnp.bc, that's $150. I think that's super fair to getting everything, all the courses together, 5 different courses with everything for $150 off, I think, for as long as you need, okay? If you need more time, no problem. We'll work with you. And we never charge you for anything. There is only the flashcards that's separate because I don't own that. But everything else is included there, okay? If anybody wants still to do the crash course, remember, my recommendation, it's based upon your time frame. So if your time frame is like, oh my God, I'm going to test like next week, absolutely do the crash course, okay? Absolutely do the crash course, because to me, it's almost insane how anybody would test without doing a diagnostic test to see where they at. So the crash course review comes with a course plus a diagnostic test, which is an added bonus that we put in as like another $60 bonus. So plus the live review, plus the WhatsApp community too, plus the forum as well. So all that's added to the $199 price for the crash course review. So that being said, Maria, can you put your, if it's okay with you, if not, you have to email me. Can you put your email here so I can fix your account while we're here right now? If you want to, otherwise email me.
Oh no, I want. I'm going to put it now.
I'll go ahead and fix. Okay, so that way I can fix immediately and I don't forget about this.
Thank you so much.
Okay, and then Yvette will go ahead.
I also had a question.
Sure.
On one of the questions that we had, we just had with the Kahoot. I didn't get the question, and I have I want to ask you more information.
Go ahead. You are breaking up, or is only me? I can only hear partially.
Okay, can you hear me now?
Yes, I can.
Okay, it said that it said that lung disease, interstitial lung disease, is a rare side effect of which drug? So you were saying the answer is SNRI.
Yes, but it's very unlikely. It's not. It was just more of a factual thing to know, right? Just in case. Hey, I have seen some questions related to that. In real life, I have never seen that. Okay, I've seen maybe case studies, right? So I just think it's a knowledge base, but it's not really high yield in application. But if either way, it's good to know, right?
Okay.
Right. So Maria, I'm waiting for your email. If you can put it in here in a chat box, it's okay with you. If not, I can search on my email and look for you.
Dr. Lopez, what time
I said it
does
now.
the crash course start on Friday?
Okay. So I'm debating if it should be 5 or 4. Is there any problem for anybody? Because it's going to be long. I don't want to take you all the way to midnight, right? I want to be respectful to your time, but I don't want to leave anything behind either. So anybody has a problem with being 4 o'clock?
4 o'clock would be better.
Can you do it 5 because I'm working?
Yes. Okay. So it's 5 o'clock. Sorry, guys. It's just has been 5 o'clock, right? Always been a 5. So for me to change it like that is not right for what's been established. That means I'll have to get up at 4 in the morning, which is totally okay for me. But also, I'm more concerned about you guys, you know. So what I want you guys to do is really look at the material before you come to the class, so that way I can be very specific to the points, and we can keep moving along. Okay. All right. So,
Dr. Lopez, did you get my email?
I got it now. I got it now. Let me just copy and paste here. And your account will be one second. Getting here your account set up. Meanwhile, is there any question between the crash course review or the other course, the PMHNP 30 days walk to success? I just want to clarify that it's a 6-month success, but if you need more time, please let me know. We can work with that as well.
Hey, Dr. Lopez, you wanted to say something to me, then somebody cut you.
I don't remember what it was. Did I have a question or?
I don't know. We were just talking about the psychopharmacology course. I don't know if that's what you were.
Yeah. So the psychopharmacology course, it should be either you are in school or you already have graduated, right? It's not high yield as far as, I mean, a lot of things will be on a board. It is high yield, but it's a long course that it may not be worth to say, okay, I'm studying for this for the board. I don't think it's what the best option, right? Now, if you say, okay, I'm in school or I graduated, then it is the best course, right? So, Maria, I just sent you a reset of a password. Please look on your trash bin.
Okay, so I will just wait. I will just wait because, yeah. No,
all right.
I'll just wait. I hope you don't forget when I have to register for the course about the money that I put towards that.
Nah, don't worry about it. We'll take care of that. So yeah, so you just want to wait. That's fine. We'll give you a nice discount that too. So Don't worry about it, okay?
Okay.
Okay. So anybody else has any questions or concerns or anything that I can help you with? Okay. So I put in a chat box NP exam coach that 30 days PMHNP walk to success there. Not that, but there is the link there. So for the PMHNP 30 days, when you go there, open the promotion PMHNP BC, you get a nice discount, make it a little bit more affordable and easier for you guys. I know, student loan and other issues are a concern, so make it a little bit easier. If you decide, hey, you just wanted the crash course review, will be live this Friday, 5 p.m. We'll try to take it a little bit faster, so arrive at least 4:40, 4:50ish, so we can get you set up. Download all the PDFs for this module, review the content, and we'll try to finish in 6 hours. Okay? As always, it was a pleasure seeing you guys today. If there is no pending questions, I think this ends today's event. If you have a question and you did not ask, please send me an email at pmhnp@npexamcoach.com. There is no silly questions. All your questions are important. If you don't understand something, if something's not clear, my job is to make it better, better, and better each time. So I don't take offensive as, oh, this person doesn't get it. I look at it, how can I make it better or easier? And I count on you guys to give me some tips. Okay, every time we're looking for improvements, every single day, every time, every day with every student, because every one of you guys are super important to us as far as we want to see you succeed. Honestly, there is nothing. First thing I wake up every morning is look who is sending me a text to say that they passed. Every single day. Like to do my prayer first, but immediately after, every single day. Okay. That being said, this ends today's event. It was a pleasure. I'll see you guys again next week. All right. Fair enough. Okay.
Yeah. Thank you so much.
Thank
My
you.
pleasure.
I got the email.
Guys,
Yeah.
study hard. Study hard. Study like you mean it. Study is like.
I was able to get the email.
Yeah. Study like you mean it. Get it done. Do